Today I am going to explain the transforaminal epidural through subpedicular approach and through Camun triangle approach. What are the comparisons, what are the similarities, differences, and anatomy and fluoroanatomy concept, geometrical concept, technical concept, needling approach. All these things will be described one by one. First I will describe the bony anatomy, then I will come to the fluoroanatomy and the procedures. So first of all, we know this is the interlaminar approach. If you take the epidural needle, so we do interlaminar approach, but many times our problem is in the anteropedural space. To reach there, this is the new technique where we can reach the anteropedural space where the disc is causing nerve compression, giving symptoms. So that's why we have to reach the anteropedural space. For that, through interlaminar we cannot reach. Through interlaminar we can reach the posteropedural space. That's why to reach the anteropedural space, these are the two techniques. One is subpedicular approach above the nerve root. One is Camun triangle approach below the nerve root. So this is the nerve root coming out. Here we have to imagine the psoas major. You can see my index finger. Index finger is the psoas major, which is totally covering the lateral wall of the foramen, or you can say this is forming the lateral wall of the foramen. So for giving transforaminal epidural through Camun triangle or through subpedicular approach, we have to keep it in our mind that my needle has to be medial to this wall. So my needle has to be medial to the psoas major. Unless my needle is medial to the psoas major, I am still into the psoas major and giving lumbar plexus, not root. You may see the root, but it is not the transforaminal epidural. We can say it is a root block, but this is not transforaminal epidural because we have to reach the anteropedural space where the disc is causing problem. Here we are getting the pseudounipolar neurons. Whether you are injecting at the epidural or on the root, patient may get relief, but my drug is not reaching at the cause where the disc herniation is there. That's why I have to come to anteropedural space either above the nerve or below the nerve. Now above the nerve, that is called subpedicular approach because just below the pedicle I can see. In the axial view, so this is the line of the lateral wall of the pedicle. So if you want to come below the pedicle, if you come straightway in AP view, so your needle may be inside the psoas major. So that's why you have to come little medial. So how much medial? So how much I will take the CM oblique? So where the lateral wall of the pedicle or outer, because here in AP view we used to see pedicle is here, but actually see in AP view you cannot see the pedicle. Pedicle can only be seen in lateral view. But what we are watching, there is a silhouette of the pedicle. We are watching the cortex of this border, inside outside. So that is the silhouette of the pedicle we are getting here. Actually this is a junction between the suprarticular process and the trans process. So you can see this lower border of the pedicle. Once you hit the lower border of the pedicle, then you are going above the nerve and as superior as possible inside the foramen. As superior as possible inside the foramen. Because we have to be very, very cautious. You can see this is the original bone. So that means I can see how much is the foramen size if this is the nerve root. So if your needle has to come so perfectly so that your needle should not touch the root. If the needle is touching the root, it will be very painful to the patient. It is not good. So I have to keep my needle as high as possible inside the foramen to do it, because when we see in the fluoroscope we cannot see the nerve. So that is the interesting part in the fluoroscopy guided procedure. What we are watching in the screen is not our target. What is our target we cannot see. So you have to imagine where nerve should be. So that imagination is very important with the knowledge of true anatomy. So if I am touching the lower border of the pedicle or the lower border of the transversus here in the middle part, so that is the last bony point. For every procedure, I believe there is a last bony point to reach the target. So there is a last bony point before reaching the target. For every procedure, we have to search a last bony point before reaching the target, so that in the AP view or in the oblique view, you cannot see the depth. So you touch that lower part of the pedicle or the lower border of the transversus medially, and then you come to laterally and enter into the foramen. So you will be as high as possible inside the foramen, and your needle is coming little medially. Now, how much oblique? So you have to take first AP view, then take the CM oblique and try to see where the outer border of the pedicle will touch the outer border of the vertebral body. So you can see this, you can see. So that is the vertebral body and outer border. So I used to say, I will take the CM that much oblique where outer border of the pedicle will touch the outer border of the vertebra. And this will be different in different level. It's not like 10 degree, 20 degree, 30 degree. For every patient it will be different, and for every level also it will be different. If it is in L1, L2 and if it is in L5S1, the angulation will be different to reach perfectly below the pedicle, because my target is I have to go below the pedicle. The technique is called Subpedicular. I cannot be straight. If I'm straight, if I'm trying to come below pedicle, I will be little lateral, I will be inside the psoas. Then once I inject the dye will show the coming more laterally, less going medially. We can see here I have kept 3 lumbar vertebrae, L3, L4, L5 in the axial view to understand the angulation of the pedicle, so that this will help us to understand the obliquity of the CM and the needle to reach the anteropetal space through subpedicular approach and medial to the source. You can see this at different levels, the angles are different. At L5 it is more, L4 it is little less, L3 it is more or less. So you can imagine what will be there at L1, L2. So this will help you to understand the real anatomy to support the subpedicular approach, needle placement and angulation of the CM to reach the perfect target. For lumbar sympathetic, we are taking the outer border of the transversus, touching the outer border of the vertebra, that much oblique, but here it will be less. But less, if it is L5S1, you will see it is obliquity is more. If it is L1-2, obliquity is less for transforaminal epidural subpedicular approach. So first step AP view, then take oblique that much where outer border of the pedicle will touch the outer border of the vertebra. You can check it, taking it more, and you will see the outer border is going inside the vertebral margin. So then again you reduce it, and at that point now you target the lower border of the pedicle. Your needle should touch here. Needle should not enter into the foramen, because you can see this, the real bone, so less space is there. If you target the foramen, you will definitely touch the nerve. In modern regional anesthesia, paresthesia technique is obsolete. That's why for everything we are doing under vision. So there we have to see how my needle is as high as possible inside the foramen, so that I can avoid the prick of the nerve. So if I am hitting this lower border of the pedicle, or if I am hitting the lower border of the transversus, so actually I am in the most superior part of the foramen. So then in lateral view, I can just turn the needle and go inside. You see here, in regular cases, what we do, we bend the needle opposite the bevel. Okay, that is up to you how you are practicing from the beginning. So this is the marking of the bevel. So I have taken the needle opposite the bevel. So first I will take AP view, oblique, then my needle is coming and I will try to touch the needle. You can see the bevel, you can see the bend is upward. So now I will come out and turn the needle and go inside so that I can avoid the prick of the nerve. Even more minutely, more perfection, I will touch here, taking the bend upward, then I will come out, I turn the needle, I will overcome this lower border of the trans process, then again I will turn it and go inside. So your needle direction is upward, it will not touch the nerve, and once you are hitting the posterior surface of the vertebral body, come out a little bit, and you will see the dye spread. Don't give too much dye, half ml, 1 ml. Just see whether dye is going medially or laterally. If dye is going laterally, still your needle is inside the psoas, you should come out, go a little more medial, so the dye should come more medially. Then only it is transforaminal epidural, dye will come more medially, hug the medial surface of the pedicle and go up. So if you think for indications, when the disc is paracentrally bulged, it is affecting the exiting route, I can block this. But if it is a central bulge on the upper level, then it will work, because then I am giving the block for traversing route. Or if you are going through the Camun triangle, then whether it is paracentral, central, for everything it will work. Now you have understood what is the technical part of the transforaminal epidural through subpedicular approach. So now let's discuss about the transforaminal epidural through Camun triangle approach. We know the Camun triangle. So here again the root is the hypotenuse. Either you take dura or superior process, that is the line. And third line is the base of the triangle, that is the lower end plate. So this lower end plate, superior process or dura, I can say, because superior process is the guard of the dura. So that is your main target. What I was telling, last bony point, here that will be the last bony point before entering into the space or into the disc. If I make this area as a square or rectangle and dividing the rectangle with this root, making two triangles, one triangle is above, that is a subpedicular, one triangle is below, that is your Camun triangle. So now we should know what is the importance of the Camun triangle, because Camun triangle mainly is used to go inside the disc. That is the main purpose for which this triangle was evolved. So this Camun triangle, basically I am going to the disc, but to give the transforaminal epidural, before going to the disc, I am keeping the needle outside the disc and giving the steroid injection. So once it is outside the disc, it is at the anterior epidural space where the disc is bulged and irritating the root. So again we have to see the same anatomy. The lateral wall is packed with the psoas. So you can see, if we see the Camun triangle, what is the relation between the Camun triangle and the psoas here. So this is the intertransverse ligament, here the transforaminal ligaments, here is the psoas major. So all these things you have to overcome if you can come little more medial. So if you see, this is AP view. If I am taking little oblique, just like for the transforaminal epidural through subpedicular approach, by this my needle will be little more lateral in the foramen, because my target to go to the middle of the disc. If I want to go to the middle of the disc, see this coronal view, see this superior process. If I am keeping like this, it is coming here. That is applicable for subpedicular approach. In the same angulation, if I am coming from here, I have gone below the pedicle, I am coming in the same angle for the Camun triangle, it will be in the lateral part of the foramen. So you can see this is the foramen here. And you can see how much distance is there from the pedicle to the annulus. Very, very less than centimeter, less than almost half centimeter, you can say. So as the disc is bulged, somehow if you can come here, automatically you are entering into the disc. But you have to be cautious that needle should not puncture the dura. How it will be avoided? You have to hit the superior process. That is your target. That is the last bony point. Here you have seen the last bony point is lower part of the trans process. Lower part of the pedicle. Pedicle is the silhouette. Reality, it is the lower part of the trans process. Whereas here, you have to see your target is to hit the subarticular process. So if I want to come to the middle of the disc, so we can see how much obliquity is needed. And if I'm coming for the subpedicular approach, what is the obliquity is needed? So that will clearly seen unless you take little more oblique, where the subarticular process is taking almost half of the disc, because that is the guard of the disc. That is the guard. If I'm coming to the middle of the disc, see, so this much oblique needed. So how much oblique? At different level, it may differ. I will take the epi view. I will square. Another important thing, when you are squaring basically through the Kambin triangle, you are targeting the disc. So disc to end plates has to be squared. Squaring of the disc is more important than the end plates of different vertebrae. Because through the Kambin triangle, you are targeting the disc, but you are not going to the disc. You are intentionally keeping the needle outside the disc and giving epidural injection. So that is the transforaminal epidural through Kambin triangle. So here, first epi view, then squaring of the vertebra, squaring of the disc rather, then take the C-arm that much oblique, where subarticular process is taking half of the disc, almost 40-50%, so that your needle should come to the middle of the disc. That is your target. Now always take the needle entry point, because you have to reach to the subarticular process. The last bony point, your needle has to touch subarticular process. That is your target. Your target is not to reach the directly foramen. Your target is to reach the subarticular process. So that is your safe bony point, last bony point. After that, you will just turn it and enter. You can see the bend of the needle. I'm touching the subarticular process, bending the needle. And after that, I'm coming out, turning the needle and going inside. In the same way, little more perfection. First, bending the needle, hit the subarticular process. Come out, turn the needle, overcome the subarticular process. And then again turn the needle, go more medial to the disc. So once you are hitting the subarticular process, 99% chance you will never puncture the dura. It's impossible. Okay. So here I will hit the subarticular process, turn the needle and go inside. So you will never ever touch the root. If you are hitting this bone, you will never touch the root. If you are hitting this bone, you will never touch the root. Okay. And as you are more medially, the dye will more come medially, less laterally. Another thing I forgot to tell you, that which number needle you will use. This is 20 gauge, yellow. For subpedicular approach, usually I use 25 gauge. That is your practice only, because my intention not to touch the nerve. But if you are not very comfortable with 25, use 23 gauge, 22 gauge. But 20 gauge is not very much applicable. Okay, because you have to think, I should not injure the nerve. But if you are going through the Camun triangle, you can use epidural needle also if it is needed. Sometimes we are doing epidural neuroplasty. We can put the epidural needle through that level and put the catheter. We can do dialysis, because enough space is there. But most important, to hit the subarticular process, there is enough space to put the epidural needle. We can think of that we are doing transforaminal endoscopy through this dilator. So what is the thickness? Imagine this. 6.5 mm scope we are putting. 6.5 mm sheath we are putting. So 6.5 mm, that space is not there subpedicular, but that space is there in the Camun triangle. So that's why epidural needle, whether it is 18 or 16, is nothing. If there is a post-laminectomy syndrome at the level of the L1, L2, L3, For that, caudal neuroplasty may not be very good, because to reach that level is very, very tough. So you can put this epidural needle through the Camun triangle and put the catheter. So you are coming into the anteropedural space, and then you can do the neuroplasty with hydradase, with hypertonic saline. So that will be much more better. Now this will be demonstrated in the fluoro. So today I will show you the difference between the transforaminal epidural through subpedicular approach and through Camun triangle approach. I have taken the epi view. Okay, squaring is done. Now I am showing the subpedicular approach at the level of L4-5. So you can see this is the AP picture, but spine is middle of the vertebra. So this is the pedicle. Here is the foramen. So but it is AP view. If you think this is the foramen, if you go here, you will be little lateral to the foramen, because the lateral wall is totally packed with the psoas. Usually we used to take little oblique. Now question is how much oblique. At different levels the obliquity will be different. So there is nothing 10 degree, 20 degree, 30 degree. The same way when you do for lumbar sympathetic, we take the obliquity that much, where the outer border of the vertebra will touch the outer border of the transverse process. Okay. So here what I realized, if I take that much oblique, where the outer border of the pedicle will touch the outer border of the vertebra. You may think it is looking like that outer border of the pedicle is touching the vertebra here. It is touching also here. At L5S1 it is not properly seen because the squaring is not done. But I will show you with how much obliquity still you will see the outer border is touching the vertebra. So I will start doing oblique and see till at what obliquity at this level the outer border of the pedicle will touch the outer border of the vertebra. So I will take the obliquity a little more also, where I will show you that outer border of the pedicle is going inside the outer border of the vertebra. So then I have to reduce it so that the outer border of the pedicle will touch the outer border of the vertebra. That is the maximum obliquity for transforaminal epidural subpedicular approach, where your needle will go obliquely medial from lateral to medial, so that it will go inside the foramen to the anterior epidural space and medial to the psoas. And then only we will get the proper dye spread, which will go more medially, hugging the medial surface of the pedicle, less going laterally. I have made it another 5 degree oblique. Still it is touching the outer border of the vertebra. So outer border of the pedicle is touching the outer border of the vertebra. You can see this picture. This is oblique because spine is not in the middle, where it was like this. So let's see till how much oblique I can take it, so that outer border of the pedicle will still touch the outer border of the vertebra. Now I think it will come at about 10 degree, but it is not more important whether it's 10 degree, 15 degree. I can see now the outer border of the pedicle is just coming inside the outer border of the vertebra. And you can see how much foramen is opened now. So you are watching obliquely. I think I can little bit reduce to make it perfectly touching the outer border of the vertebra. Now I am taking at about 15 degree. I have increased the obliquity a little bit. Let's see where the pedicle comes. We can see now the outer border of the pedicle is quite inside the outer border of the vertebra. So that means I have to reduce the angle. Now I have reduced the angle. Now you can see, you can compare with this picture. It was earlier. You can see here how much it is inside, and after reducing the angle, you can see the outer border of the pedicle is touching the outer border of the vertebra. So this is the final position to start the procedure for subpedicular approach for transforaminal epidural. So now my target is the lower border of the pedicle. Whether you say 5 o'clock, 6 o'clock, 7 o'clock, whatever you say, ultimately you have to target here, because as it is oblique, already you will come medially. Here is the psoas will be here. So my needle should touch the lower part of the pedicle. I will not touch the nerve. If I come here, I will touch the nerve. So if I am touching this lower part of the pedicle, or actual anatomy wise the lower border of the medial part of the trans process, so then I will hit there intentionally, because that is the last bony point to reach the target, without knowing, because X-ray cannot show you the depth. If I go straight away here, I don't know what is my depth. Unless I see in the lateral view, I will not be able to see that depth. So that's why if I am hitting this lower border of the pedicle, then I will go to the lateral and I will see my needle is just posterior to the foramen, and I will come out and turn the needle below and go inside the foramen in lateral view. So I will be at the upper part of the foramen, so I will not touch the nerve. Then in lateral view, I will hit the bone, I will withdraw little bit, I will inject the dye, and dye will be seen in lateral view going up and down in the anterior epidural space. And when it will come to the epi view, I will see needle will come from obliquely, and the dye will hug the medial surface of the pedicle and go up. It will go less laterally. If I inject too much dye, it may go laterally. But if you are injecting 1 ml, 1.5 ml, then dye maximally will come medially. And if you see in this picture where the angle is little more, so if I target now here for transforaminal epidural, I will be quite lateral, because I have taken more oblique. So that's why this is the better position. So now I will show you the needling. So I have taken the marker just below the lower part of the pedicle, because we have to think I am taking the marker at the skin. It is not at the target. So still the journey is left from the skin to reach the anterior part of the foramen. So that's why I've taken the entry point little below, so that my needle will go up and to hit the lower part of the pedicle, and then I will come out and come below the pedicle to reach the anterior epidural space. Usually I take 23 gauge, 25 gauge for transforaminal epidural subpedicular approach, but here in cadaver I am taking the little thicker needle, that is 20 gauge. We can see the marker is showing, that is the bevel. I used to practice bending the needle opposite the bevel. So in that way, some people they may practice opposite way, but your orientation is up to you, how you are doing it. But most important thing, how I will play with the needle, that is the important part in this intervention. Now after little manipulation and going ahead, I am touching the lower part of the pedicle. Always you have to keep it in your mind that fluoroscopy pictures are magnified pictures. So here, even if you think I am going little above the lower part of the pedicle, but the distance may be in millimeters. So now I am just posterior to the foramen. I will take the C-arm lateral and will see where is the position of my needle. I am now hitting the lower border of the pedicle. Now we can see we have taken the lateral picture, and let's see what is the needle and what is the anatomy. We can see here the vertebral body. This is another vertebral body. So this is the disc. So here is the foramen, one level above. So this is your inferior articular process, superior articular process. This is one foramen. Now at this level where I have gone, because this is the pedicle, so it is a subpedicular approach. You can imagine here you will get the trans process because it's a lateral view. Now needle is just touching the lower border of the trans process, lower border of the pedicle, So here is the foramen, posterior surface of the vertebral body. Now I will turn the needle and enter into the foramen. Now you can see, I can see the dot here. That means the direction is upward. Now it is hitting the bone. I will come out and turn the needle and go inside. Let's see what the picture comes. See here, you can see the needle has gone into the foramen. Again, I'm showing the anatomy, vertebral body, disc, and the vertebral body. This is the body, upper end plate of the lower vertebra, suprarticular process, infrarticular process, facet. So here is the pedicle, just below my pedicle. It is coming here. I can go little ahead to hit the vertebral body. For little more correction, or I should say for little more perfection, I can see my needle is going looking down. So once I cross this hurdle, that is the lower border of the trans process, I can again turn the needle so that needle will go up. So let's transfer the picture first so that I can make the difference between these two maneuver. So what I did, I will come out just to show you. I was hitting the bone. Now I have come out. I will turn the needle, go just overcome the hurdle. Again I will turn the needle and gone inside. Now I will see what is the picture of the needle in the foramen. See there, the needle is looking upward, and see there earlier needle is looking downward. In both the cases I am in the foramen, but in this case it is away from the nerve, better than this. This is little more perfection. So after hitting the lower border of the trans process or lower border of the pedicle, then you are turning the needle in lateral view and entering into the foramen. Then again you are turning upward and going inside the foramen to be more upper part of the foramen away from the nerve. Now after hitting this vertebral body, I will withdraw a millimeter and I will inject the dye to see in lateral view, dye should come up and down, and I will see the root will come like this way. And in epi view, dye will hug the medial surface of the pedicle and go up, and root will come down. Let's see in the epi view also. So now again I have come back to epi. I should say rather true epi, and compare with the picture of the lateral view and the epi view. You can see here in epi view, needle is coming from lateral to the medial. Why it is true epi? Because the spine is in the middle of the vertebra. So at every level, how much oblique you have to take for the subpedicular approach? It is the outer border of the pedicle. When it is touching the outer border of the vertebra, that obliquity is needed for that particular level. Now if I inject the dye should go up, touching the medial surface of the pedicle. Dye should more come medially than laterally, because laterally the psoas is there. If the dye is coming more laterally, then still your needle is into the psoas. Needle has to come the medial surface of the psoas, because that is forming the lateral wall of the foramen. So now I will compare with the transforaminal epidural through Kambin's triangle. Now if I try for transforaminal epidural at one level above, say at this level I will do transforaminal epidural through Kambin's triangle. First is the squaring of the disc. You should not say the squaring of vertebrae, because disc is my target. Many times because of the patient's spine, different types of lordosis, the whole vertebra, they may not be possible for squaring. So my target is the disc, because when I'm going through the Kambin's triangle, my target is basically the disc. So my target will be first to square the disc. So then I will take the CM that much oblique, where the suprarticular process will almost come to the 40-50% of the disc, because suprarticular process we have seen, that is the protection for the dura. So that much, now this much is opening. This much disc is open. So if I go like this way, it will be in the foramen, but it will be quite lateral to the foramen. I can go inside the lateral part of the disc. But if I want to go to the center of the disc, I have to take the supraarticular process that much inside, so that that much disc will open, so that I will be able to go to the center of the disc. But I will not go to the disc. I will be outside the disc and give transforaminal epidural through Camun's triangle. So this is squaring of the disc. Now I will take the oblique view. During this obliquity, we have to think about the C-arm, because C-arm cannot take much oblique on the left side of the patient, whereas on the right side we can take more obliquity. So in that way, your target may be different little bit when you are coming for the left side or you are coming for the right side. That you have to keep it in your mind. So here it is a maximum obliquity we have done in the fluoroscope for the left side. So you can see this is the disc. Supraarticular process, very, very important thing here. You have to keep the C-arm in such a way that supraarticular process is not only coming almost 40-50%, but also it is taking the maximum part of the disc. Because here is the Camun's triangle. So when supraarticular process is maximum taking the part of the disc, so nerve will not come in your pathway, nerve will go up. I am comparing with the upper level. See here, supraarticular process is this much taking the disc, if this is the part of the disc. So then nerve will come at this level. If you are trying to go inside the disc in this position, so if you are coming here, the nerve will be there. So this is very, very important part. It is not that the supraarticular process is not there in front of the disc. It is which angle I am watching through the fluoroscope, in that is depending. So I have to keep the supraarticular process inside the disc so that it is actually guarding the dura, and if I am targeting here, nerve is gone up. So I will compare this part. If I change little bit cephalocaudal, I will show you how this supraarticular process is going down if I take the C-arm little cephalad. Okay. So when I'm changing this obliquity, you can see where the pointer is now, though it is not much needed, just to show you the changes. So it is coming around, 5 point. Okay. So now I will take the C-arm little more cephalad. That means the image intensifier will go to cephalad. Now we can see where it is coming. So earlier it was the right side of that 0. Now it has come to the left side of the 0. So that much cephalad, the image intensifier gone. Let's see what is the picture, what is the position of the supraarticular process in respect to that disc. See this now. See this, where is the position of the supraarticular process and where is the position of the supraarticular process. See again, supraarticular process has come down. If I think this is the disc, supraarticular come down. If supraarticular process come down, so basically I am watching from above, so nerve will come here. So at this point, if you are trying to go to the disc, you will definitely touch the nerve. See here on the other side, supraarticular process is covering the almost disc, so nerve has gone up. A small calculation, geometrical calculation, will help you not to touch the nerve. So this is not a good position, whereas you see in the upper part, supraarticular process gone more below. And here, see the differences. So again I will take the picture in this way and I will do the procedure. Again I have come to the earlier position, taking the image intensifier little corded, and you can see where earlier the marker was there, and now I will see after taking the shoot. So here you can see the supraarticular process is taking the almost maximum part of the disc. So nerve will be here. My target is here. my target is to touch the subarticular process, not to go to the disc. There is the last bony point before entering into the target. Always try to find out which is the last bony point before entering the target, so that you are safe, you know the depth, and then only you are entering into the target. Otherwise, without knowing the depth, because AP view, oblique view, it cannot show you the depth. Unless you see the lateral view, you cannot see the depth. So better to touch the bone. So we can see this line, that is the lateral border of the, actually there is no border, is the lateral surface of the subarticular. So I can say it's a two-dimensional picture. I can see the lateral border. So I will take the point little more lateral. Why lateral? Because this point what I am taking, it is I am taking at the skin, not here. As my needle is bent, so this much, say needle is half centimeter medial or half centimeter laterally bent. So in that way, this half of 1 centimeter extra space I need to play here from coming from the skin to reach the target here. When I will reach there, actually my needle will touch this bone, and once I touch it, then I'm very, very safe. Then I will turn the needle, I will go a little further to touch the annulus, I can feel that, and I will finish the procedure after watching lateral view, the transforaminal epidural through Camun triangle. Compare with this picture and the real picture here. So what is happening? My needle is coming like this way and touching here. Okay, you can see that's the, I'm hitting the subarticular process, then turning the needle and going inside. Okay. So this surface actually showing here this part. It is showing a line, but actually it's not a line. You can see it's the surface because it's a two-dimensional picture. So when I will start the journey, I will take little lateral because I am taking the needle at the skin. Then I will see till I am hitting this bone, I should not cross this line. Very, very important line. Again, I am telling. I will take the entry point here. I will take the needle from lateral to medial, and I will start journey, and I will try to hit this, and I will try to touch this line. Before I am touching this line, I will watch my needle should not cross this line medially. If I am crossing this line, I am posterior. That means you see here, see my needle is coming like this way. I am touching this line. If I am crossing this line and not touching this bone, then I will be posterior. If I am touching this line, because I am coming from behind, I am coming from behind. If I am touching this line, that is the safest, and then only I will turn it and go inside. You will never ever touch the nerve. But if it is showing in the picture that I am touching the line but not hitting the bone, and then I am advancing, I am crossing this line, I will be posterior. So I think you have understood what I told you. So this is the border, which is my focus. When I am taking my journey, I will hit this line and turn the needle, go inside. If I am not hitting the line, don't go to other views. Finish the oblique view, then only you will go to the lateral view and finish the procedure. Otherwise, if you keep on changing epilateral, you will be puzzled. So you target this line. Before touching this, don't cross this line. If you cross this line, you are posterior to the subarticular process. So I have taken the marker. You can see where is the marker. Marker is not at the tip of the or at the side of the subarticular process. It is little lateral to the subarticular process, so that I am taking the point at the skin. When I will reach, I will touch the subarticular process. Let's see how the needling will be done. Now I have taken the needle in such a way I am hitting the subarticular process. This is the most important thing. Don't try to enter into the disc without touching the subarticular process. If you touch the subarticular process, so then you are much more safer. So now I will turn the needle and enter into the disc. See here. Now you can see needle is directed medially. You can see the pointer here. So that means it is opposite the bevel. Now I will come out a little bit, turn the needle and go inside. See? can see the picture. See, now you can see the needle is turned. And same like the subpedicular approach, after overcoming this hurdle, I will turn again medially and enter into the disc or touching the annulus. So earlier I was touching the bone now. Okay. You can see I am touching the bone, coming out, turning, overcoming the supraradicular process, then again turning, going inside or touching the annulus. So let's see what is the picture comes. Yeah, you can see now the needle has gone medially. So now I have crossed the hurdle and again gone medially. So you are below the nerve, here is the nerve. Now I will see in the lateral view to see how the needle is touching the posterior annulus. Or if you are using ozone, you go inside the disc, give ozone, and in lateral view slowly you come out, and once you are coming out of the annulus, then you can inject the dye and give the transforaminal epidural through Camun's triangle. So now let's see the lateral view where I am. Now I have taken the CM in lateral view and took the picture. Let's compare with the oblique and the lateral view. See the anatomy. This is the vertebra. This is another vertebra. By watching the end plate, you can find out the foramen. If you do the upper end plate of the lower vertebra, see this will be continuous as a supraradicular process. Then lower end plate of the upper vertebra, this will be continuous with the pedicle and infraradicular process. So this is the facet joint. So I have just crossed and come into the anteropedural space, about to enter into the disc or just entered. So at this point, I will see injecting dye. If dye is going up and down, not going inside the disc. If you're going inside the disc, you have to come out a little bit. And you will feel that giveaway when the needle will come out from the hard annulus. And then dye will come like this way for the nerve, because ventral root comes like this way. Dorsal root goes like this way. This will be the anterior epidural space dye spread, and nerve root will be like this. And if we see AP, and we will see dye is showing the roots and epidural fats. Let's see what is the AP view. So this is the lateral view. This is the oblique view. Now I will see the AP view. Now again I have come to AP, and now we will compare with the AP and the lateral view. So we have seen already, this is the lateral view. Needle is just posterior to the disc or just entering at the disc. And here it is the AP view. Now we can see it is just like your transforaminal epidural, the same level needle. It is here the subpedicular approach. You have come little inside the foramen. The psoas will be there. Now dye spread will come like this. So as it is cadaver, I have not injected dye. In my patients, I will show the same procedure with the dye spread. So you can see where is the needle. Needle will come medial to the facet. Unless needle is coming at this level, this is the facet. In AP view, you are not little inside the foramen. So this is the Camun's triangle approach of transforaminal epidural. Thank you.